Good evening, everyone. Thank you for joining us today. We will be talking on the management of colorectal cancer, and it's my pleasure to introduce you our today's speaker, Dr. Joe Goldberg. Dr. Goldberg is a colorectal surgeon at Brigham and Women's Hospital in Boston and assistant professor of surgery at Harvard Medical School. Thank you, Dr. Goldberg, for joining us today, and please feel free to begin your presentation.
Thank you very much, Marta. Welcome to everybody. I hope it's not too late at night there in Ukraine. I look forward to teaching you a little bit about colorectal cancer. This is most of my practice as a colon surgeon. I do colorectal cancer and I do inflammatory bowel disease. And so maybe I'll talk to you in a few months about inflammatory bowel disease. So today I'll talk a little bit about colon cancer and then a fair amount about rectal cancer because the management is much more challenging. And in the last 10 years, there's been lots of advances in rectal cancer treatment. And it's important to know some of the new treatments. Although the outcomes are not much different, there's a lot of new treatments. So in the United States, there's about 150,000 cases per year of colon and rectal cancer. And that's about 325 to 350 million people. That number has stayed the same. 30 years ago, when I was a junior faculty member or a resident, like some of you, we had the same 150,000 cases, and there was only 250 million people. And so this number has steadily gone down because of colonoscopy and screening. Removing polyps and screening people decreases the rate of colon cancer. So it's about 5% of the population will have either colon cancer or an advanced adenoma in their lifetime. So it's pretty common. It's the second most common cancer, both in women in the United States. It's now not third most. It's even the second most cancer, and it's the second most common cancer killer. And so it's very common. I know that it's common in Europe, developed countries, South America, Japan, Korea, Australia, Israel, other westernized countries. It's very common. And what we're seeing now is we see less cases amongst old people, and we're seeing an increased number of cases in young people. The increased number of cases in young people is not due to less cases in the older people so that it's a higher percentage. It is actually a absolute increase in young people. So we went in the United States from 1% of people having colorectal cancer being young, so 1,500 a year, to now almost 10,000 people, between 6,000 and 10,000. So that's a real increase in the number, and we're not sure why. So about 5 to 10% of all colorectal cancers are due to genetics. They're due to Lynch syndrome or HNPCC, which is a mismatch repair deficiency. And the four most common are listed here: MLH1, MSH2, MSH6, and PMS2. These are different genotypes. Within each one of these, the mutation in the gene can be at a different location, and the presentation can be. Just because you have MLH1 mutation, your family might not have as high a penetrance of colon cancer, so the phenotype might be low, meaning the expression of the gene. It has to do with everything, environmental influence, as well as the genetic defect. Different defects have different penetrance. The other main cause of hereditary colon cancer is FAP. That's in the adenomatous polyposis coli gene. And this results in cancer in 100% of people by the 40 in the normal variant, and in attenuated FAP, that usually presents in the 40s, 60s, so the rate of colon cancer is less. And I would say the third type of colon cancer is the mute YH polyposis, which is the recessive form of FAP. And those are really the three major inherited types. The risk factors that are environmental, other than these genetic inheritance, are smoking, drinking, cured and processed meats, obesity, and probably inactivity. The differences in the distribution of colon cancer is 20% are in the right colon, only 15% are in the entire descending and transverse colon, and then 65% are in the rectum and sigmoid. So the vast majority are left-sided, although we're starting to see an increase in right-sided, and very little are in the area in between the right and the left colon. So what are the symptoms? The main symptoms are, as you know, anemia, bleeding, obstruction, changes in bowel habit, and weight loss. That's for colon. And for rectum, they're pretty much the same, except patients will get thin stools, they'll get tenesmus or pain, more of a pressure sensation. And these are because the outlet is obstructed. Farther up in the colon, you have less of these outlet obstructive symptoms because the stool is more liquid. And so it's important to ascertain the difference. Really, the tenesmus and the pain and the pressure can also be due to invasion of the sphincter muscle. So the workup includes, as you all know, colonoscopy, CT scans to rule out metastases, anything in the liver that's suspicious should get an MRI. I know because Dr. Melnichuk and I were talking about PET scans, that there's not a lot of PET scan machines in Ukraine. It's rarely indicated, so you're lucky that you don't have them, because in America, everybody asks for a PET scan and they don't need it. So it's good that for you guys that there might not be so many. It's very unusual to need a PET scan. We basically use it for lesions that are difficult for us to biopsy, but we have a high concern that it's cancer. And so if it's difficult or dangerous to biopsy, there's a high concern and it's a bigger size, then we can use a PET scan to look and see if it's cancer. The labs are pretty straightforward. The main one that is the tumor marker is CEA. We find that 15 to 20% of patients in the States are malnourished. So we check nutrition labs, which is prealbumin. And the other thing for the diagnostic workup really is only for rectal cancer, and you need either an MRI or an ultrasound to stage the rectal cancer. So when you do surgery for colon cancer, how do you determine what's quality surgery, right? So we can all take out the tumor and stop the bleeding, stop the obstruction, but we really have to determine, have we appropriately staged the person so that we know that they're truly a stage 1 or they're truly a stage 3. And that difference is because stage 1 and stage 2 patients don't get adjuvant therapy. Maybe stage 2 patients, if they have a high-risk tumor, will get adjuvant therapy. But the vast majority of stage 1 and stage 2 patients don't get adjuvant therapy. And so we have to know that people are adequately staged. And so probably 20 years ago, the first paper started to come out in the United States where they looked at people who had 0 to 7 lymph nodes, 7 to 14 lymph nodes, and more than 14 lymph nodes. And what they found is people that had 0 to 7 or 7 to 14, if they were node negative, meaning no lymph nodes having cancer in them, but they were less than 14, those patients were like people who actually were node positive, versus the people who were node negative and had 20 or 30 negative lymph nodes, and they were a T3 or a T4 lesion in the colon, those patients actually acted like they were stage 2, meaning their survival mirrored the stage 2 patients. Whereas the people who had less nodes, they acted more like they might have had a positive node. And that was because there was inadequate node harvest. So fast forward about 15 years, about 5 years ago, some papers were written that showed the minimum number of lymph nodes to harvest is 12. If you get 12 lymph nodes, you have a 95% certainty that the patient will be adequately staged, meaning that if they have 12 lymph nodes, you know, and they're negative, you know they're node negative. Clearly getting more lymph nodes is better. I have many patients that have 2 or 3 lymph nodes that are positive, and if I only have 12, they have a much higher rate of recurrence than people who have 200 lymph nodes that are harvested that are negative. I use that as an example because I've had a couple of patients where the pathologists have gone nuts looking for lymph nodes, and they've looked at 200, and the patients have 2 or 3 positive lymph nodes. Those patients do much, much better than the patients that have 2 or 3 positive and only have 12. So the current thinking is the more lymph nodes you get, the better it is, because you actually know that there's no more lymph nodes. The other things about quality surgery are, when you do your operation, you want to get one named vessel on either side of the tumor. So for a cecal or right colon tumor, you want to get the ileocolic with the ileo branch and the right branch of the middle colic vessel. If you have anything, that's anything up to the hepatic flexure. Anything between the hepatic flexure and the middle colic vessels, you'll want to take the middle colic vessel as well as the ileocolic. And anything to the left of the middle colic vessels, you'll want to do a left colectomy and take the left colic vessel in all the branches of the IMA. The other thing that's critical is you want a negative radial margin. So if on your imaging, this is for colon cancer, you see the tumor growing into the duodenum, growing into the pancreas, abutting the abdominal wall, very infiltrating into the retroperitoneum or the iliac fossa, then if the patient's obstructed, you should operate, but you should do a bypass. Patients that you leave a positive radial margin in colon cancer, they will have a local recurrence. Chemotherapy and radiation will not treat that margin. Okay, so if somebody has an advanced colon cancer it's a T4 lesion growing into another structure and you surgically cannot get a negative margin, then you should do a bypass or do a proximal ostomy, and that patient should get adjuvant chemotherapy to shrink the tumor, and then you should go do a resection. Negative radial margin is very important as a quality control for colon cancer. And of course, we always want to think about restoration of GI continuity. That applies more to rectal cancer, but it's also important in colon cancer. So how do we stage people? It's the TNM staging, tumor nodes and metastases. Colon cancer is generally clinically staged based on the CT scan, basically rules out stage 4 disease. And then we generally look mostly at pathologic staging. So once the pathologic staging, I'll get back to that because that impacts adjuvant therapy. But surgery is the primary treatment modality for colon cancer. The goal is to remove the tumor with a negative margin and all node-bearing tissue on one named vessel on either side with at least 12 lymph nodes. So the extent of the surgical resection depends on the location of the tumor. And I've outlined here for right colon cancer, you want the ileocolic and right colic vessels, right branch of the middle colic. That's a right colectomy. For proximal transverse colon, you want all of the above and the middle colic vessels. That's an extended right colectomy. Distal transverse colon, you want to take the middle colic vessels and the left colic. That's an extended left colectomy. Descending colon cancer, you want the left branch of the middle colic and the left colic vessels. And the sigmoid colon, you want the superior hemorrhoidal and all the sigmoid branches. And for the rectum, you want to take the superior hemorrhoidal or the IMA high, and that gives you a low anterior or an APR resection. So these are the operations that we do depending on the location of the tumor. The rectal part, obviously, I'm talking mainly about colon cancer now, but I include that here. So who gets adjuvant treatment for colon cancer? Well, chemotherapy is depending on your findings at surgery. So the adjuvant therapy treats the systemic disease. So that's node-positive disease in patients who have high-risk features predictive of metastases or node-positive disease. So these patients are patients with positive lymph nodes, patients with T4 lesions, and patients with high-risk features, which include poor differentiation, lymphovascular invasion, perineural invasion, obstruction, and perforation. So the indications for chemotherapy is everybody with stage 3 disease. That's any node-positive patient. It gives about a 15 to 30% survival advantage to patients who get chemotherapy. The worst stages derive more benefits. So a stage 3C, somebody with more than 4 positive lymph nodes, will get a 30% survival advantage to getting the chemo. Whereas somebody who has a 3A that has 1 positive lymph node probably gets very, very low benefit, at most 15%. And probably if you had 1 positive lymph node out of 50 or 60, if you really drilled down and looked at the data, you probably would not see much of a survival advantage to the chemotherapy. But the adage is 1 positive lymph node, people get chemotherapy. The standard treatment now that shows survival advantage is FOLFOX chemotherapy. That is 5-FU, leucovorin, and oxaliplatinum. The platinum is an infusion on the first day, and the 5FU people get for 2 days. They get 6 to 12 cycles, 2 weeks apart. After that's done, patients enter active surveillance with physical exam and lab work every 3 months and CT scans every 6 to 12. In our practice, if somebody has a stage 3A or a stage 2, they get CAT scans once a year. If they have 3B or 3C, they get CAT scans every 6 months for the first 3 years. After that, we would go to 1 year for the advanced stages, once a year to 5 years. And if you're a 3A, you would stop getting CAT scans once a year, even after 3 years, because 80% of recurrences occur within the first 2 years. 80% of recurrences are in the first 2 years. So that means if you have a 70% survival from your stage 3 colon cancer and you don't recur in the first 2 years, 30% of the 30% that are going to recur, 24%, that's 80% of 30, occur within the first 2 years. So that means after 2 years, if you haven't had a recurrence, your chance of a recurrence is only on the order of 5 or 6%. So it goes way down. So it doesn't make a lot of sense to continue getting CAT scans and giving people excess radiation and spending lots of financial resources for finding very few late recurrences. So surveillance after chemotherapy, colonoscopy is year 1, then 3 years later, and then every 5 years after that. CT scans are 6 to 12 months, as I mentioned, depending on the stage, and you get them at least through 3 years, 5 years for stage 3B and 3C. The younger the patient and the more advanced the tumor, we're more likely to get them for up to 5 years. CEA, 3 times, every 3 months for 2 years, then every 6 months for 3 years. Pretty standard follow-up. Now let's talk about rectal cancer. This is where let me stop for a second. Any questions on colon cancer?
I had a question. You mentioned that one of the points of quality surgery is restoration of continuity, but sometimes during left colectomy, do you use preventing stoma? Do you form it, or like not every single time? Because I know institutions where this is the rule.
So in low anterior resection for rectal cancer, anybody who has radiation, anybody who has an anastomosis 6 centimeters, set below 7 centimeters. So people who, if it's a LAR for rectal cancer, we give a diverting stoma for radiation, below 7 centimeters, steroids, male, colitis, okay, malnutrition, and not for all of those. The only one that and diabetes, those are the major risk factors for leak. So for rectal cancer, the only one that's 100%, I would say, would be radiation. I've never not diverted somebody who was radiated. The ones that are a little bit less, that are more up to judgment, would be depending how malnourished they are, the diabetes, obviously male, Crohn's or colitis, depending, like if somebody had rectal cancer with a mid-rectal cancer with Crohn's disease on ileocolic and nothing in the rectum, then I wouldn't feel the need to divert them. So basically it's how low the tumor is, and radiation are the biggest factors. So somebody who has a coloanal or an anastomosis that we can palpate within 1 to 2 centimeters, maybe 3 centimeters of the sphincter, we probably divert all of those people. And radiation, definitely. The other ones are more subjective. But the more of those you have, the greater the chance of an anastomotic leak. Now, so for colon cancer, the only people that I would divert would be people with Crohn's or colitis that I was resecting a cancer on that left side, and I was worried that they might have, subclinical active disease, or for somebody who had a perforation or somebody who had an obstruction. So if people have perforation or obstruction on the left side, and I do a resection and an anastomosis, I would probably give a loop ileostomy for those patients. The right side, almost never.
Thank you.
One more.
Markian looks like he wants to ask it.
Yeah.
Yeah, thanks. I have a few. What do you think about routine D2 or D3 lymphadenectomy for the right colon cancer?
I go all the way up to the junction of the middle colic and the ileocolic with the with the SMV. So I believe in that. I believe in certainly the peritoneal surface is intact. So what you would call, what you're, I think, suggesting is a total mesocolic excision. I believe in that. I do that almost every time. I think it's probably so controversial. There's some evidence, depending on where you look. I know there's some pretty fair evidence from Germany that shows that there's a survival advantage amongst the people who get a total mesocolic excision versus those who don't. The problem with total mesocolic excision, unlike total mesorectal excision, is it's a lot harder to measure the quality vis-a-vis photo documentation, right? It's very easy for rectal cancer because I have some pictures. It's very clear if somebody does a good TME. But for colon, it's a little bit harder. I would think that I believe in it. And I think if you do a high ligation, you're going to get more nodes. So if you did something that was considered total mesocolic excision and you got 15 nodes versus you did a resection that maybe somebody might not call total mesocolic excision, but you had 80 nodes, I would still think that the person who had 80 negative nodes is going to do better if you had hundreds of patients like that. So I think the key thing is doing a high ligation, getting all the nodes and not violating the peritoneum, certainly around the area where you have palpable nodes. Is that helpful?
Yeah. And if we are talking about the right colon, what your preferred approach? It's like medial to lateral, lateral to medial, uncinate approach, or maybe below to up.
What was the other approach? You said lateral to medial, medial to lateral.
The uncinate approach, going through the D3 part of duodenum.
Okay, so I've never done that approach. So what I do is, it depends on the technique. If I'm doing robotic, or if which I do a lot of, or I'm doing laparoscopic, I do medial to lateral every single time. The robotic, I call it medial to lateral, but what I do is I ligate the ileocolic high, and I make a window underneath the ileocolic medial, and I make it over the ileocolic on both sides, and then I ligate it, and then I do my dissection underneath the mesentery of the colon all the way up onto the kidney, behind the hepatic flexure, over the pancreas and the duodenum, all the way down to the cecum. This is for laparoscopic and robotic. And then I take the cecum and I work from the cecum up, and I free that up, and then I enter the lesser sac, because I keep the person in a little reverse T-bird, and then I enter the lesser sac, divide the gastrocolic omentum, and then I take the middle colic vessels and the right colic vessels. And if I'm doing a robotic, I do an intracorporeal anastomosis. So I take the omentum off, clean up the colon, divide the ileum, and then I do an isoperistaltic anastomosis. Whereas if I do laparoscopy or open, I exteriorize the bowel for the anastomosis, because you don't have the same articulation with the robot. If I'm doing open, I tend to do lateral to medial, just because it's easier. Every once in a while, if the residents ask me, I'll do medial to lateral open as well, simply because it's the same anatomy that they see when I do it robotically.
And last one about the transverse colon. If we are talking about the tumors in transverse colon, T4 tumors, do you try to resect the gastrocolic ligament and nodes on the right gastroepiploic artery?
So when you say a T4, you mean T4 on the surface?
Yeah.
Yeah. I would take a margin all the way around it and take any gross lymph nodes, but I wouldn't take the gastroepiploic if I didn't think there were large nodes there.
Right.
But if there were large nodes there, I try to clear all the visible disease that I can safely, because people, if they have a lower tumor burden, they respond better to chemo. One thing that I always tell our residents is 30 years ago, when I was where you guys are, and I was a young man, because I'm only about 6 or 7 years from retirement age here in America. I'm 59. When I was in my 20s, we had a whole bunch of studies that said debulking doesn't help in colon cancer. Well, we now know, and this is before FOLFOX chemotherapy, before FOLFIRI, and you know, before cetuximab, and before Avastin, and frankly before all the new therapies that are coming out with CAR T-cell therapy and immunotherapy. So really, I think now all those studies from when I was a resident are off the table. That debulking doesn't matter, because we know that people that have peritoneal disease in several places, that if you can cytoreduce them to 90% of what they had, the remnant tumor is going to respond better to the chemotherapy, and those people actually live longer. And for colon cancer, not even heated intraperitoneal chemo, just systemic chemotherapy with debulking. There was a study in France, the PRODIGE 7 study. So for rectal cancer, I'll talk about PRODIGE 23. For PRODIGE 7, I think it was 7, showed a 1% difference for the patients who had HIPEC with maximal debulking intraperitoneal chemo with maximal debulking and IV chemo, such that in colon cancer, we don't do HIPEC anymore unless they have pseudomyxoma. And that might still be pretty rare. So in general, I try to debulk as much as I can, but if I don't see disease there, I wouldn't take the gastroepiploic off the stomach.
Thanks.
Any other questions?
Okay, we have one more raised hand from Victor Chervonochenko.
Oh, Victor. I can't see you, Victor. No questions unless you show yourself.
Can you see me now? I have some problems with camera.
I'm teasing you, Victor. Go ahead.
Okay. So the question is, what is your preferred strategy for synchronous liver metastasis?
A very good question. So if we're doing a right colon, and we'll pretty much do any synchronous operation with a right colon, because you can do it through the same incision. If you make a Coker incision or the robotic, everything is set up, or laparoscopic, it's all set up the same. Upper midline, Coker incision. If we're doing a left colon, or and they're getting a right hepatectomy, it's a much different incision, so we tend to stage them. If we're doing a couple of wedges on the liver and we're doing a robotic LAR, we'll do those at the same time. But if we're doing an APR, we won't do that with a liver resection, because the patients often will form quite a bit of ascites. And if you have an APR and they're making ascites, then they're going to leak out their perineum. It's going to be tough to wound heal. So right colon's always, transverse colon, yes. Left and sigmoid just depends on how big a surgery they're getting, and LAR. But in general, for those, only if we're doing wedges. If we're doing a formal right or a formal left, we stage the left side. APR we never do at the same time with the other lesions.
And do you ever do liver first strategy?
Excellent question. My research resident for next year is going to look at our results of liver first versus liver second and see if there's a difference in survival. The liver surgeons always like to do liver first, because if the patient has received a lot of chemo, they don't want us to do our surgery, then have a big delay, and then have a growth, and then not be able to do theirs. Do you see what I mean? But my guess is if the liver tumor grows that fastly, or an extra 6 weeks matters, probably doesn't matter for the patient. They're not going to do better. I'm a proponent of colon first, to be honest. I think I'm in the group of people that thinks metastases come from the primary, that the vast majority of metastases don't metastasize.
And one more question, if you don't mind. Do you always do neoadjuvant chemotherapy for such patients, or you can do surgery first and then give the patient adjuvant treatment?
It depends whether they're symptomatic or not. If they're symptomatic, then we would do the colon first. If they're symptomatic and it's a rectal, we would do a diversion, okay, and then go to treatment. If they have just a couple of liver mets and they look like they're curable, then we'll, if it's colon or rectum, we'll start with chemo first to get in several cycles of chemo, and then we'll give them a break and do their surgery, or give them a break and do their radiation. In somebody who doesn't have liver metastases, we usually start with radiation and then go to chemo for the rectal cancer. Radiation and then chemo if there's no metastases for rectal cancer. If there are metastases, chemo, then radiation, unless we think we can get by without radiation, in which case we'll just do chemo and then go to surgery, save radiation. If they're not curable, we would base it on their symptoms.
Thank you.
Of course, is that helpful? And
Yeah, very much.
all right, so in the States, we have about 40,000 cases of rectal cancer per year. This percentage is the same across Western societies, the percent. So about 40% of what we see is rectal cancer. There's several differences from colon cancer from the rectum. Narrow pelvis, pre-treatment is the norm. Recurrence can be symptomatically a major problem. All treatment is based on your pre-op imaging. And the bottom one is my little addition, is all patients are worried whether they're going to have a permanent colostomy. Everybody just, that's all they don't care about any of this other stuff. It's just, do I need a bag? Everybody asks us. You have to be prepared early on to answer those questions. And that'll obviously be based on your examination. Staging is the same for colon, except for the T4A and B, because there's no extraperitoneal, there's no visceral peritoneum. Pre-treatment staging. We use MRI to stage the T and the N stage. The MRI is accurate 90% of the time. For the T stage, 70% for the nodal stage. There will always be over-treatment and under-treatment of the patients due to the inaccuracy of the MRI staging. So patients are like, well, why are you going to give me all that treatment if you might understage me? And I said, all of the trials that we do are done with everybody getting an MRI. So the results of the trials also have patients that are overtreated and undertreated within them, right? So if the trial has the results of undertreatment and overtreatment, we're going to get the best results by treating the people the same way we treat the trial. So I never try to guess. I always base it on the imaging. And sometimes at our conference, some people say, oh, I'm just really worried about this patient, or I'm not so worried about that one. And I always pipe up at the conference on our conference on Friday morning. If we don't believe the imaging, then we're not functioning or treating people with data. We know the data is not completely accurate, but that's baked into the hundreds of patients that we take care of. So you have to believe your imaging and you have to use it. That's how I feel. All right. The TNM staging. Overall stage 1 for rectal is T1, T2, N0, M0. These patients all get upfront surgery. Stage 2 is A through C. That's T3, T4, N0, M0. These patients all get neoadjuvant therapy, unless if they're medically fit. Stage 3 is NET, N1 or 2, M0. These patients get neoadjuvant therapy. And stage 4, A through C, A being single solid organ, B being 2 solid organs, and C being peritoneal disease. That stage 4C has the worst outcome by far, rapid progression. So anybody who has M1 disease, it's patient dependent, MD dependent, and symptom dependent, as I answered in Victor's question. You guys they're going to get these slides, right, Marta? Everybody,
No.
They won't have my slides? Oh, okay.
No.
Okay. Well, I think the talk is being videoed, so they'll be able to watch it. They'll be in there. So what are the factors that we consider in rectal cancer? Some of the factors that we consider are in the treatment are how far is the tumor from the anal verge? Okay. So in a woman, the rectum is 0 to 15 centimeters. The rectum is 12 centimeters in a woman. Above that. In a man, it's 50 centimeters. The upper rectum can sometimes have upfront surgery because we treat it a little bit more like colon cancer because the benefits are much less than mid and low rectal cancer. So in my mind, the patients that are T3N0 that have an upper rectal cancer, those are the patients, that's the earliest that somebody would get pre-treatment with neoadjuvant therapy. So if you have an upper rectal cancer, I will often sometimes just go to surgery first if it's at 15, 16 centimeters. Because often if you're wrong, or if it's a T3N0 and you get 35 negative nodes and your anastomosis is above the peritoneal reflection, you could skip the radiation and just go with chemo, right? So I sometimes will do surgery for upper rectal cancers. However, upper rectal cancers that have T4 disease or N2 disease, I treat those like mid and low rectal cancers. This histology of the lesion, the high risk features for rectal cancer, means that up to a third to half of the patients have lymph node metastases. And I have them listed here: poor differentiation, lymphovascular invasion, perineural invasion, tumor deposits. So if you see any of this on your pre-op MRI, these patients, or your pre-op biopsy, the patients need pre-treatment because their risk of having positive nodes is very high. The lymph node metastases, this is important to remember, directly correlate to the depth of tumor invasion. So T1 is a 6 to 8% chance. This is what allows us to do transanal excisions in early rectal cancer. You cure 92 to 94% of patients with a T4 lesion, with the T1 lesion and a transanal excision. And in the 6 to 8% that have a positive node that have a recurrence, you can salvage 3/4 of those people, or 2/3 of them at least, with chemotherapy, radiation, and then radical excision. So in the end, if you take a T1N0 and your MRI was wrong and they had a positive disease and they have a recurrence in a couple of years, you're still going to have an overall cure rate once you treat those people and do resection that's close to 96, 97%. If you did an LAR up front in all of those people, you wouldn't do much better than that. And the outcome from a symptom standpoint or quality of life is much better with the transanal excision. So for T1N0, that's the standard treatment. T2, there's about a 20% chance of positive lymph nodes, so those numbers don't work anymore. You need to pre-treat those people. And T3, it's a 50%, T4 is 80%. So the key concepts in the management of rectal cancer are local control, overall survival, organ preservation with quality of life, LAR syndrome versus colostomy. These are the things you have to talk with a patient about. Locally advanced disease, diagnosed by MRI or ultrasound pre-op, is T3, T4, N0, or NET with node positive disease. So stage 1 rectal cancer, T1N0, the local excision criteria are no differentiation, no high-risk features, no neural invasion, no tumor deposits. Has to be within 8 centimeters of the anal verge unless you have a robot or a TAMIS, and you can get higher. Less than 40% the circumference of the rectum, and you need to have 1 centimeter margins. Here's a picture of a local excision. This is done, as you can you see my arrow? This is all excised, and we're going to close it from here all the way down and up here around. And we are doing this, this is a robotic excision. Here's a specimen. As you can see, the margins were probably, these are more than 1 centimeter laterally, and up here and down here, distal and proximal, they've retracted. I suture it to a towel and I mark it, and then the pathologist will measure the margins and ink it. So what are the outcomes? So why do we do transanal excision? Better quality of life, sphincter preservation, no LAR syndrome, no multiple stacked bowel movements, preserve sexual function, less risky surgery. Higher recurrence rate though, 10 to 20% versus 7 to 8 for an LAR. So yeah, that recurrence rate is due to the positive lymph nodes that are read as negative on the initial MRI. They will grow and grow into the bowel wall. However, if you remember the math that I went over on the previous slide, the survival is equivalent simply because you can salvage most of the people that have a positive lymph node that recur. So we can offer this due to the low chance of lymph node metastases. So what about T2N0? These patients have up to a 20% chance positive lymph node. So these patients can have upfront surgery with LAR or APR, or if they're really concerned about quality of life or don't want an ostomy, there was a study done by the American College of Surgeons Oncology Group. These people had chemotherapy and radiation followed by local excision. And it was a single-armed trial compared to historical controls. And it showed at 5 years compared to historical controls, there was the same survival rate. And 50% of these people had a complete response. So the reasons to offer is no ostomy, better quality of life, equivalent survival, and local recurrence rates. But they have to get the chemotherapy and radiation. T2N0 with local excision alone is not adequate treatment. So stage 2 and stage 3 rectal cancer, why do we do neoadjuvant chemotherapy? Well, it's because of the positive nodes or the large tumors. High recurrence rates. The recurrence rates are very problematic. Invasion of nerves, bleeding, pain, obstruction. What I often tell people who are concerned about their temporary ostomy or about all the pre-treatment is I said, if you don't do this, you're going to have a recurrence, and then you're going to still end up with an ostomy, and you're not going to be curable. So it's better to have a temporary ostomy or a permanent ostomy if they need it, be cured, than to not have it and then end up with it because you had inadequate treatment. So the 3 things you need to think about when treating rectal cancer are local recurrence, sphincter preservation, and survival. And these are all impacted by chemotherapy and surgery. Radiation impacts local recurrence and sphincter preservation. It does not impact survival. So the patients can get neoadjuvant chemotherapy and radiation in any one of several patterns. They can get 6 weeks of radiation, 28 treatments of 180 with 5 FU, rest for 8 weeks, then surgery followed by chemo. That used to be the standard 10 years ago, maybe even up to 5 years ago. That's all we did. It was very easy. Everybody came in. If it wasn't T1 or T2N0, that's what they got. Okay. Now we have total neoadjuvant therapy. Okay. So people can get radiation five doses of 500 by like the Swedes do in Sweden, or they can get 28 by 180. And as you can see, it looks like it's about 50% of the radiation, but the 5 by 500 is really almost 4,000 effectively. It's like 3850. So it's much higher. The patients all, no matter which one of these 2 they get chemotherapy with 8 cycles of Folfox. They can get either one of those radiation regimens ahead of time, or they can get it after the chemo. Okay. And that all of those 4-arm trials compared to the standard treatment is what people call the OPRA study, organ preservation rectal adenocarcinoma. And we found that the patients who have the radiation first and the patients who have the long course radiation are more likely to be complete responders, and the long course patients are less likely to have an early recurrence than the short course. So the standard way, if you don't feel particularly concerned that about the aggressiveness of the tumor, or if they have they don't have an isolated liver met where they're still curable, then we would start with long course radiation followed by 8 of Folfox, followed by rest period, followed by surgery. If the tumor was particularly aggressive, or they had an isolated liver met that was curable, or an isolated lung met, we would start with the Folfox, then go to the radiation, and then go to surgery. Or we would start with 5 by 500, because that only takes a week, and then they can go right to chemo. I think either one of those is fine. The benefits of the TNT therapy is people get all their chemotherapy and radiation up front. They're more likely to complete all their therapy. Remember, everybody's willing to have their surgery, but if you do their surgery first, some people throw in the towel. It's time for the chemo. So this is the real benefit. As I said, there's a dropout rate if people get upfront surgery. Survival appears in the vast majority of these patients to be equivalent, but patients can get a chance at non-operative management, never have surgery, avoid a permanent and or temporary colostomy, and have fairly equivalent survival rates. So once again, here's the same thing I talked about, the fractionation of the radiation. It's the surgery with LAR versus APR. Pretty much everybody who gets chemotherapy and radiation first gets a diversion, and the chemotherapy, people get 8 to 12 cycles of Folfox. So neoadjuvant therapy. So I'm going to talk about the main studies for rectal cancer, which is called the foundation. They set the foundation for the treatment of rectal cancer. And all of these came before that description I just gave you of the OPRA study. So The Swedish study in the patients were accrued in the mid-90s. It was reported in the late 90s. They did surgery alone versus short course radiation and then surgery. They had 5-year follow-up. They saw the people that had the radiation had 11% local recurrence. The people who only had surgery had 27%. The problem is people weren't doing total mesorectal excision at the time. Right? Bill Heald hadn't popularized TME. So the problem is people were getting bad surgery. So the radiation made up for bad surgery in this study, okay? The other problems were a third of the patients were stage 1. So they were given radiation to people who were gonna do well anyway. There were more stage 1 and stage 2 patients in the surgery in the radiation group. So that group was gonna do better whether they got radiation or not, okay? They didn't have good randomization and the patients weren't standardized to TME. All of that being said, it showed such a profound difference that we still talk about this. It's the only study of any study in rectal cancer that shows a survival in the radiation arm. But the problem is that survival is probably because there were earlier stage patients in that arm. Had nothing to do with the radiation, had to do with patient selection. The Dutch trial is the exact same thing as the Swedish trial, but they standardized people to the TME. So people had the exact same surgery. The 2-year rate of local recurrence was 5% overall in both groups. The local recurrence rate, if you had radiation and surgery, was only 2.4%. And if you just had surgery, it was 8.2%. So substantial difference, but much less than in the Swedish trial where they weren't standardized to TME. So this study proves 2 things. It proves the radiation is helpful and it proves that TME is critical. Radiation is helpful, TME is critical. 10-year follow-up, they showed only 5% local recurrence in radiation with surgery and 11% in surgery alone. So 90% of people with good TME will not have a local recurrence in the pelvis. So if they've had prior radiation or they have a reason they're contraindication to radiation, you can still do well in almost 90% of your patients with surgery alone if you do good surgery. And in this study, at all iterations and at all analyses at 2 years, 5 years, and 10 years, there was no difference in survival in the radiation or non-radiation group. The German trial compared pre versus post-op radiation. Pre-op chemoradiation, then surgery versus surgery, then chemoradiation. They standardized to long course chemotherapy and radiation. So 6 weeks, 5.5 weeks of 180 units each time, 28 treatments. Standard TME, post-op, both groups only got systemic 5-FU. Okay, local recurrence rate was 6 in the pre-op XRT, 13 in the post-op XRT. There was no difference in survival again. The post-op group who got had lower completion rates of chemotherapy and chemoradiation because some people had surgical complications and never got to it. There were more complications and toxicities in the post-op treatment group, meaning they had worse bowel function. But in the pre-op group, there was increased sphincter preservation and a lower local recurrence rate. This study was done based after 3 years of accruing patients, at least 3 years for every patient. Some patients had 5 or 6 years, but the average was 3 years. The results were so significant that they were able to publish in the New England Journal of Medicine with an interim analysis. When they followed every patient out to a minimum of 5 years, some patients were at 10. They showed that this 6 versus 13 shrunk to 10 versus 7, but it was still statistically significant. So pre-op is better than post-op, less complications, more sphincter preservation, better quality of life. TME is critical, radiation is important and very useful. So the summary is that pre-op chemoradiation provides better local control, no difference in survival, but less complications. It was unclear back then whether short or long course was better. Short course was cheaper, more convenient, but a question of higher fibrosis. And now in the Oprah study, earlier local recurrences. The long course had better shrinkage. So big bulky tumors always use long course, better sphincter preservation because that's what the German trial showed, and there were less complications. There was a trial in Poland that compared short course to long course, and they showed no difference, but there were some problems along with like the Swedish study. Okay. So the Mosaic trial showed that there was a survival advantage to getting FOLFOX versus 5-FU alone. So some patients are diabetics, they have neuropathy, so there is a problem with giving them the platinum agent in the oxaliplatinum. So, but if the patients can tolerate the FOLFOX, they have a survival advantage. This is a critical trial in rectal cancer. One of the trials, we've talked a lot about radiation, but let's talk about the Prospect trial. That was just published a little bit less than a year ago, and it looked at the standard therapy of chemoradiation followed by surgery followed by FOLFOX versus just pre-op FOLFOX and no radiation. They entered anybody that was node positive, T1, 2, 3, or 4 node positive, excuse me, T1, 2, and 3 node positive, T3, N0. Nobody could have an APR, nobody could have N2 disease, and no T4 disease. So it was that solid group of middle rectal cancers where the patients didn't have a threatened margin or lots of positive nodes. And we looked at FOLFOX, give enough shrinkage, same survival, same local recurrence. And what we found was that in the Prospect trial, we found that solid group of middle rectal cancer patients that didn't have a threatened margin, that the overall survival was the same in the group that got radiation and the group that didn't get radiation. And the sphincter preservation rate was the same, and you were able to often avoid a temporary ostomy. And if the patients were in the group that had a local recurrence, you could give them radiation at a later date. And it was also good for women who were young for childbearing because they didn't have radiation. They had chemo, so if they harvested eggs, the uterus might still be functional. So there are many reasons. Also, with the increased young patients, number of young rectal cancer patients that we're seeing, you know, in 30 years, somebody might need, or 20 years, they might need radiation for their cervical cancer or their uterine cancer or their prostate cancer. So not using it upfront for their rectal cancer has distinct advantages. So I talked about PRODIGE earlier. The PRODIGE 23 study is chemotherapy before chemoradiotherapy. And the goal was to decrease distant recurrences. So these are really for high risk aggressive tumors. And what happens is the patients get FOLFIRINOX. So they get FOLFIRI with oxaliplatinum for 6 cycles. Then they get chemoradiotherapy for long course, 28 days of 180 units. Then they get TME, and then they get the rest of their FOLFOX, 6 cycles of FOLFOX. This was compared to the standard of care chemoradiotherapy with TME and then 6 months of FOLFOX. The disease-free survival rate in the PRODIGE 23 group was 76% versus the experimental 69%. So in this therapy with very high-risk cancers, there was a survival advantage. So some conclusions are the pre-op radiotherapy decreases local recurrence. Okay, it increases sphincter preservation, no difference in survival. If people get TNT therapy, they increases the completion therapy for all patients. It increases the pathologic complete response, so some people can get non-operative management. The repeato is when people get 5x500 radiation instead of the 6 weeks. This has less high risk, less failures for distant disease, but more failures for local disease. So getting people to their chemotherapy sooner is important. Okay, here's a picture of a TME. You can see right here is the IMA. Here's the proximal margin. Here's the distal margin. You can see this entire package is complete. The mesorectum. Here's the IMA. This is a different view. The IMA, and here's the TME. All of the fat node-bearing tissue posterior to the rectum is intact. And here's another picture. So who do we do non-operative management on? We do it in lieu of surgery after people have a complete clinical response to neoadjuvant therapy. It avoids morbidity of surgery, mainly APR. In our group, we only offer this to people who need APR or coloanal. Bowel dysfunction, ostomy, low anterior syndrome, incontinence. You avoid all of that in people. You avoid sexual dysfunction. You avoid urinary dysfunction. Can you avoid mortality with this? Okay. There is a little bit increased mortality in people who have non-operative management. Okay, so if people are clinical complete responders and they decide to have the surgery anyway, they versus the people who are clinical complete responders and decide not to have the surgery and take their chances, there's a 5% increased mortality in those patients that don't have surgery. That means they have a local recurrence. We thought they were a pathologic complete responder because they were a clinical complete responder, but they had microscopic disease that we couldn't see on the endoscopy, the digital exam, and the MRI. They have a recurrence, it spreads, and that's what kills them. The clinical complete response is about 30 to 40% of patients. There's no rectal tumor at post-treatment on digital exam, on endoscopy, and on MRI. The risk, local recurrence is up to 25%. This compromises the local outcome. So of the 40% that have a complete response, somewhere between 25 and 50% will recur. And of those people will only be able to salvage 75%. So 75% of the 20% that recur is 5%. That's where you get the increased mortality. So the decreased overall survival is 5 to 6%. So selection, who do we choose this on? Low tumors, the ones that are amenable to surveillance with rectal exam, they have also bigger benefits to non-operative management because they would otherwise need an APR. The higher tumors that are earlier stage, they benefit from proctectomy, maybe even without chemoradiotherapy. You can't survey these people with digital exam, you can only scope them and do MR. So high tumors that are early stage, T3, maybe go right to surgery. Mid-rectal tumors that are advanced, you probably want to give them pre-treatment and then go to surgery. And the low tumors that need an APR, you would want to consider non-operative management. So here's a chart that shows the incomplete response endoscopically. I'll show some pictures in a minute. There's a hard palpable mass, there's stenosis. Patients will have restricted diffusion in the area of the tumor. They need to go to surgery. Near complete response will have some irregularity, no visible mass or ulcer, but they'll have some restricted diffusion. They need to be reevaluated in 6 to 8 weeks. Whitened scar that's flat, smooth surface, no restricted diffusion. These people can go into non-operative management surveillance. Here's some pictures. So here on the upper left is the original tumor with the associated MRI. In the upper right, you can see there's still palpable residual tumor. This is an incomplete response. Here's a near complete response. You can see this huge, ugly looking tumor, and there's just a small white flat scar, but it's slightly raised. Okay, here's a complete response. Here's the kind of an ugly looking tumor. If you think about it, it's kind of ulcerated, sticking out. Right here is just a flat white scar. This is the person that gets non-operative management. So to summarize the major trials for rectal cancer: Swedish, radiation decreases recurrence; Dutch, TME is very important, probably more important than the radiation; German, pre-op is more important than post-op. The Polish trial showed that short and long course are equivalent. OPRA showed that long course is better than short course, and in people without distant disease, radiation first gives you more complete responders, more opportunity for non-operative management. The Rapido, when you use 5x500 followed by chemo, then surgery or non-operative management, that shows that if you go to 5x500 and give them chemo first, give them early chemo versus the standard therapy, there's less distant recurrences. The Prodige is for the really risky tumors with upfront FOLFIRINOX, then X-ray therapy. The certain patients have better survival. So what's our practice? We make recommendations depending on the location of the cancer and the stage. Upper rectal, stage 1 or early stage 2, we go right to surgery, like I said. We avoid overtreatment with chemotherapy or radiotherapy. The chemo can be given post-op with the same efficacy, and you might be able to avoid the radiation, especially with negative nodes and good thick margins with posterior tumors. Upper rectal cancer's advanced stages, we would do the prospect trial, go to chemo first. for 3 months, then surgery followed by completion of chemotherapy. And if there's a threatened margin or N2 or T4 lesion, we would add the radiation up front. Midrectal cancers that are early and small, like T1, you could try a transanal excision if you can get that high. If you can't, we would still do LAR. Stage 2 or N1 disease, we would once again do the prospect study. Advanced stage 3 midrectal cancers, big tumors, lots of nodes, we would give them the chemotherapy and radiation up front. We prefer chemo radiation first, followed by the chemo. We assess for a clinical complete response. Surgery in everybody who has cancer. Watch and wait for patients who can't have sphincter preservation, meaning an APR. Surgery for the younger patients or for those who cannot undergo surveillance. The young patients were a lot more concerned. You know, it's one thing we don't like to make a mistake in an 80-year-old, but if somebody's 80 and you choose non-operative management and they have a recurrence in 3 years and they die in 5 years, that's a lot different than if you do that in a 40-year-old. Bulky advanced tumors, all chemoradiotherapy up front, reassess the response with MRI, flex sig, and rectal exam. Bulky or advanced mid-distal rectal tumors, if they have a clinical complete response and they want to be watch and wait, we will. The follow-up is flex sig and rectal exam every 3 months for 2 years and every 6 months for after that for 3, 4, and 5th years. MRI every 6 months to 2 years and then annually every year from 3, 4, and 5. CT, chest, abdomen, and pelvis annually to look for distant disease. If they have a persistence of the tumor or a recurrence, they go to surgery. And that is it.
Thank you very much, Dr. Goldberg, for such an amazing, informative talk. Actually, I know we have exceeded the lecture time, but may I ask you if you have some time because we have a couple questions.
Yes, of course.
Okay,
Sophia,
thank you.
You're up.
So please, question from Sophia.
Good evening. Thank you so much for a great lecture. And you mentioned that you try to divert patients before the chemo and radiation. Did you do it routinely or if it's only risk of obstruction?
I only do it if they're obstructed or very symptomatic. If somebody had an upper rectal tumor, they didn't have mets, we would just go to surgery if they were symptomatic. And I might take out the primary if it was upper. If it's low, then I would divert them.
And if you don't mind, one more question. How to manage patient with low rectal cancer and active Crohn's disease, especially if it's an active phase and on-target therapy? How we combine this therapy together?
Yeah, so I'm actually have my research resident this year going to be looking at all of the Mass General Brigham patients who have IBD, meaning ulcerative colitis and Crohn's disease, and we're going to look at the MR staging because I think it's much worse than the T stage of 90% and the N stage of 70 to 80%. I think we're probably only right 50%. So if you're only right 50% of the time, I think that you have to give strong consideration unless it's a clearly, very obviously early tumor. You have to give strong consideration to pre-treatment for all of those patients. Because if it's rectal cancer and UC and you want to do a J pouch, if you're wrong on the staging, right, then the patient can't get radiation. And if they have a threatened margin, that's a big deal. In Crohn's disease, I would continue the biologics because we know that there's no increased complications while people are on biologic therapy, anti-TNF therapy. Matter of fact, they do better if they're on their TNFs with surgery. And I don't think there's any increased cancer risk for GI cancers. It's mostly for things like melanoma, okay? And so I would continue their biologics. And once again, in Crohn's disease, I would be really, you're less likely in rectal cancer and Crohn's disease to do an anastomosis because they're not going to heal and they have active disease. So I would err on the side of radiation up front because I think we understage these people. I think they're a much higher stage in general. And if you're going to give them an APR anyway, there's little downside to radiation pre-op. There's a lot of downside post-op if their small bowel ends up in the pelvis, because then they have Crohn's and they have radiated small bowel.
Thank you.
That answer your question, Sophia? Good. Okay, Victor.
Thank you for your lecture. The question is, if a patient comes to your office and the patient is operated, the patient has been operated elsewhere, and on the CT scan you see that there hasn't been an adequate lymph node dissection. For example, you see that the vessels haven't been ligated high. Would you offer a resection for such a patient to complete the lymph node dissection?
So I think if somebody had their IMA clearly intact, you know, in America, we're all fat and have high cholesterol, and, you know, everybody used to smoke, so nobody's IMA is intact here. I'm joking. But if somebody came in and they had like 5 lymph nodes and they had an inadequate resection, we discussed it at the tumor board, we'd probably take that person back to the OR, or we would treat them as if they were stage 3 with chemo. If it's a high lesion, if it's a low lesion, we probably just treat them, because, you know, the problem is if you re-resect them and it's low, they might end up with a permanent colostomy, right? So I would have to have a heart-to-heart with that patient and say that they didn't have good surgery. I wouldn't use it that way. I would say we're very concerned because we don't think there was enough lymph nodes found. You know, because you never want to throw somebody under the bus unless it's Putin. So no laughs. You know, so you don't want to say, you know, I would never say that another surgeon did bad surgery, but I would say that the pathologist or we didn't get enough lymph nodes. So if somebody had a high tumor, and I could hook them up easily, I would definitely go back if they didn't have enough. But if it was a low tumor, then I would just err on the side of treating them.
Thank you.
Yes. Markian?
Yeah, thanks for the great lecture. What do you think about stents as a bridge to surgery?
As a bridge to surgery? I love it. Sigmoid, and it has to be mid to upper rectum, because if it's a low rectum, the stent will be into the sphincter and cause tenesmus. So yeah, I believe it. I like it. So one of 2 things: put the stent in, prep them, clean them out, and then you can do one of 2 things. You can either go to surgery up front, and then you could do post-treatment, depending if it was upper rectum or rectosigmoid. We've recently put a stent in somebody because they were obstructed. The whole colon was dilated. We were able to prep them and clean them out. I gave them the loop ileostomy, and then they were able to get their neoadjuvant therapy and then go for their resection. The GI doctors don't like that, because then the stent's in there for 6 months and they're worried about migration and perforation. But I just think we need to have you need to have a discussion with them about a plan. They don't like to put stents in and leave them unless the patient's terminal within the last 3 months, right? So they don't like to do that. So you just have to have a discussion, doctor to doctor, colleague to colleague. But in general, I use them a lot for bridge, but it has to be the right patient.
Okay. And what about the circulation tumor DNA as a marker for prophylaxis or a recurrence, like the after the definitive surgery?
The studies in this country, in the United States, are still ongoing, but we generally, in some patients, we're checking it. It's expensive, so not all the doctors check it. The oncologists don't check it in everybody, because they want to see they don't think it should be done outside of a trial, right? Because if you spend $800 to $1,000 and the trial doesn't show a benefit, then you wasted a bunch of money on people and the insurance companies. So, I mean, I think that in the next decade, I'll retire in exactly 11 years from this summer is my plan, when I'm 70. My bride is 5 years younger than me. So she's really not a bride anymore. We've been married 25 years. But anyway, she's younger than me. So when she's ready to stop working, I'll stop working, because I actually like her. So I want to spend time with her. So I think that the ctDNA will be much better in a decade. I think we'll have other tools. And I think we might be treating more people with upfront chemotherapy, non-operative management, and ctDNA like adjuncts to follow people. I think there will be plenty of disease for us as colorectal surgeons and surgical oncologists, because not every patient is going to survive and they're going to need surgery. And there's an increasing amount of IBD. And the diverticulitis that we're seeing is much more aggressive, right? There's always going to be lots of anorectal disease. So I think the future is bright. I think that using things like ctDNA are going to be able to help us, help people. I think the hard part about ctDNA is, and the studies are, if it's positive, but there's nothing on imaging, you don't have a target to go after, right? I'm much more interested in looking at colonoscopy and ways that we can get screening people earlier. My research resident is going to be working on a project looking at these young colorectal cancer patients, looking at the cost of colonoscopy, because in the United States, we just lowered the age from 50 to 45, right? Because there's lots of young people getting it, but we're probably only capturing another 2,000 cancers out of 10,000. Whereas if we did Cologuard or FIT test or fecal occult blood with Flex Sig, all of which are much cheaper, we could probably start screening everybody at 25 for the same cost. And then we would capture 10,000 cancers and probably save more lives. So we're doing a cost-effective analysis along those lines. So that's really my research interest. The thing is you're going to find cancers. ctDNA, you're not going to really find the cancers, right? And if you have a positive one, to me, the thing about ctDNA is we have to know the false positive, right? If the false positive is 20%, you're going to be getting a lot of scans and giving a lot of people radiation that they don't need. And then once you know the true false positive rate, right, then you need to know the true positive rate, and you need to know the false negative. So all of those matter, because you want to look at how many people you're radiating, giving excess radiation. What does it cost? Then you can't find something, and what's the downside to the excess radiation, right? I do think that in the early stage cancers, certainly stage 1 and probably stage 2 patients, it's probably not going to have much role. It won't have much role. In the advanced diseases, it'll probably have a decent role. The current technology. That's my feeling.
Thank you.
Yeah. Victor.
In addition to a question about stents, I've seen an article where it was stated that stents versus a loop ostomy gave poor outcomes in terms of lymph node metastasis and N1C metastasis. Did you observe such a tendency in your clinic? And what do you think about stents versus enostomy?
So you mean if you put a stent in, you're more likely to end up with positive nodes or tumor deposits?
Yeah. In general, the oncologic outcomes were poorer in patients with stents.
Yeah. So the problem with that is, I haven't seen the study, but I can tell you the criticism would be this. You would need to have all those patients have a pre-op MR or pre-stent or pre-ostomy MR. You would then need to put in a stent or an ileostomy, randomize the patients, do another MR and treatment, and then have your pathology to compare. Because my guess is that you're seeing a worse result, because a lot of people that have more advanced disease are going to be more likely, with obstruction, are going to be more likely to have positive nodes or tumor deposits, right? And if the colon's really dilated, one of the things is if they're completely obstructed and you give them an ostomy, you run the risk of a closed loop obstruction. 30% of people have a competent valve. It's one thing to have somebody cleaned out, right? To have a stent in place, a partial obstruction, clean them out, and then go to 6 months of therapy with a bowel that's collapsed and only passing mucus. That's very different than, leaving somebody nearly completely obstructed with a dilated colon, potentially with a closed loop with an ileostomy. So I haven't seen the study, but that would be my concern. I know what they're trying to say is putting the stent in does something to the physiology that causes people to get more nodes. I think if the patient has obstructive symptoms, but you're able to prep them and clean them, then they should certainly just get an ileostomy. They should not get a stent because it's another procedure that runs the risk of a perforation. And in the end, you're going to need your ileostomy anyway. So you might as well use that. Right. So, but the problem is the people that are really, really dilated and obstructed, giving them a loop ileostomy if their colon is filled is not always the best solution.
Thank you.
Thank you. Thank you very much for your questions. We had a productive discussion and we didn't mean to overwhelm you, Dr. Goldberg.
No,
All this questions.
I was late.
But
I was a few minutes late, and we're doing great. This was fun.
thank you. As we're closing our session, I would like to thank Dr. Goldberg once again for finding the time to share your expertise, and to all of our participants for active engagement, and wish you all the good evening. Stay safe, and we hope to see you in our next session. Thank you very much.
If you have any questions, you guys can get my email from Marta, and I'm happy to take email questions. You can give my email, Marta.
Okay, great. Thank you.
Okay, bye-bye.
Bye.